Welcome back from lunch. So excited to have you here, as I said before, and we have a special gift today. It's what I hope is sort of a very engaging and far-reaching conversation with our own New York State Health Commissioner, Dr. James McDonald, and our fantastic Emmy Award-winning moderator, Carol Jenkins. And as I've said earlier, people's bios you can use the QR code at the top of the Learn More and Get Involved sheet to get a lot more detailed information about the people who'll be speaking today. And so the idea is that they'll have a conversation and then we'll make sure we have time toward the end for folks to engage. So welcome.
Thank you. And thanks so much, Kate and Columbia. Chris, are you there? I'm going back to you. Sorry. Thank you for your work and for Kate's great work. And Dr. McDonald, thank you so much. I told you as we met outside that I woke up this morning and you were on TV, and I thought, how convenient, So I paid great attention to what you were talking about, which really relates to our subject today. And that is, the maternal paid leave so that women can actually go to their appointments. And especially in a state where Black women are like 5 times more likely to die for giving birth than their white counterparts. And I know that you're just on the job. Welcome back to New York, and you are working on that. But tell us about the maternal paid leave.
Yeah, thank you, Carol. And it is, I have a microphone that didn't seem to want to have a conversation with me. There we go. Yeah, no, it is great to be back. And by the way, Kate, thanks for the warm introduction. I don't think I've ever been described as a gift before. So that was special. I have to tell you, I remember that. But so we did talk about, so in the most recent budget in April of 24, the budget gets enacted in New York State every year. So starting January 1st, which I think isn't too long from now, like 3 weeks from now, right? So what will happen in New York State is something called paid prenatal leave. So in other words, if you work in New York State, no matter who you work for, privately employed, publicly employed, doesn't matter, you start the year with 20 hours of paid prenatal leave. So you can use that to go for prenatal checkups, which are obviously important, right? In other words, you want to see how your baby's doing, and you could use it for fertility visits. You could even use it for an end of pregnancy visit. And, one of the things that's important about this in New York State is your employer can't ask you to prove you're pregnant, or can't really even ask you, just like you start the year with 20 hours. And if you need the time off, you work that with your employer. And I think it's one of those things where the first state to do this. And what's interesting to me is it seems like something that's nice, but shouldn't this be something that's required of every state? Like, why isn't this something that's normal in our culture? And I think it gets to so much of what goes on in the United States. Like, I've traveled the world a little bit, and in other parts of the planet, people look at health very differently. In other words, it's considered something everybody should have access to. It's something that people should actually be experiencing in a positive way. And it's something people should have time in their life to do, because people are supposed to live their life. And in the United States, we grew up with this culture of work, 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 work. And then if you get a moment, you go healthcare. And it's funny, I'll tell you this quick story really quick. Like, in Europe, you have an out of office message. Someone might say, I'm off for the summer. See you in the spring, right?
I know. We
Whereas
all know that
here,
story, right?
In the United States, out of office messages, I'll be out of the office for 2 hours. I'm having knee surgery, but I'll have my cell phone with me at every moment. And we take ourselves far too seriously here at work. I lead a state health department that's one of the largest in the country. I try to bring a little bit of balance and perspective to it. Trying to get work-life balance. It's a little harder than, maybe for some other people, but if I can try, you can try.
I know. Well, I'm sure every single person in this room and every person watching has the same question, the same thought. Why are we like this? I am so glad that you were raising that. Are you coming to answers other than that we're taking ourselves too serious? It's not just mean-spiritedness. Something else.
I think it's the rugged individualism that put our country together, if you will. It's funny, having lived in Japan for a couple of years, there's a whole different mindset a little bit. Part of it's that rugged individualism. Part of that's work ethic we build even into our kids, and I think it's one of the things we have to be just a little bit thoughtful about, even as parents, is one of the things I think about as a parent and as a pediatrician too is that, children play and they're supposed to play. You should play too as an adult. You should find a little bit of time every single day. Right. But if you should find time for play in your own life every day. And if you find time in your life, even as an adult, to play, I think it'll make you a little bit more balanced in life. And it's funny, I think the French in some ways have this a little bit more wiser than we do. The mandatory retirement age there would be 62. That's what starts the third age when you get to play
Well,
for the last 20 years of life.
I'm thrilled to hear a person in your position expressing these concerns and thoughts, because maybe they will lead us to the future. And I know that that you have a favorite cookie recipe
I do.
that you love to share.
Yeah.
And so we're going to put that up on our website, just so that we don't have time to go into all of the details now, but I'm delighted to know that our health commissioner has a cookie recipe.
In my third year of medical school,
Yes.
I got a chocolate chip cookie recipe.
Yes.
And I've been working on perfecting it for many years.
Yes.
If you're
Okay.
going to eat a cookie, eat a good one.
I know, and we're assuming, right, that cookies are good for you. That
I didn't
chocolate
say
chips are
that.
good for you.
No, I never said that.
Right. Okay, but that's. I do want to say welcome back to New York. Many people may not know that you were here for many years. Went to international,
I
but
went
you
to
most
Earth.
recently
Oh,
you were in
yeah.
Rhode Island, right? And so thank you for coming back, and come from a family of generational people working in the health field. Your grandmother, your mother, your brothers, and all of your brothers have names that start with J as well,
That's
right?
right. It's one of the odd little things my mom and dad thought would be good to do. But yeah, no, it's funny. My grandfather owned a pharmacy, opened it in 1931. It's still there today. But I grew up as a kid, sweeping floors and working in a pharmacy. I thought that was normal. I thought everybody did that. I thought everybody at the age of 12 went to work and got paid 50 cents an hour. That's what I thought was normal. And sweeping floors and, stocking shelves. And I thought that was the most amazing thing to do, right, on Saturdays. But, it was really a very big advantage for me, by the way, growing up in a family where there was a family business.
Right.
That was a powerful source of alternative health for me because, even though I was doing things as I went older, counting pills in a pharmacy, actually that made pharmacology a lot easier in medical school because I already knew the names of the drugs. Didn't know what they did, but that's what medical school was for, right? But that was how my family there was one of their advantages they gave me. It was a big advantage.
Right. And we were talking outside again, too, that about your children with autism. I have a special needs child as well, just so that our audience here and there understand where we're all coming from in this conversation.
Yeah. I mean, I have 3 kids, 2 have different forms of autism. And I was sharing with my oldest is Noah. Noah's autism is pretty impairing, but he can drive. And he just got his first full-time job at age 25 as a dishwasher at a place that's a school for kids with autism. And it was a dream come true for me in many ways because it's 3 miles from my home. Doesn't have to take any highways to get there. He gets paid time off. He has a predictable schedule. And it really harkens back to one of the Surgeon General's reports, right? Like when you look at work-life balance, one of the things people really need is a predictable schedule. And it's nice to have paid time off. These are really powerful. And then my youngest son has a very different form of autism. He is struggling through community college. And when I say struggling, I mean working hard. Like my Christopher, he is a worker, but he goes uphill and it is a slippery slope. But he fights to go uphill every day as he's trying to accomplish his goals in life. And I have a lot of admiration, respect for him. But they've made me a better dad. They've made me a better leader, and they made me a better public health physician. Because one of the things I really see is I've had to learn how to explain complicated things to people who don't always understand me. As a pediatrician, I learned to do that. But one of the things I've recognized too is not everyone perceives me the same way. And so it's important to put things in ways that people understand. And that's one of the things they've done to help me be a better person.
Great. Well, now that we know something about you, we can move on to the breaking news of probably the decade. And that is that come January, we have a new administration. There are a lot of people in this room, and myself included, who are concerned about what that means for our children who are living in poverty. I think we're putting the figure for the country at 13 million who are disadvantaged, deprived, some of those homeless, some of those food insecure. What are your thoughts about the things that we hear? Slashing, is it $2 trillion from a budget? we're afraid that means that our kids are endangered. What are your thoughts?
Yeah, I think as we look to the federal transition, we're looking at the New York State Department of Health a couple different ways. One is the mission of the state health department, which is protect and promote the health and well-being for all, built on a foundation of equity. That mission doesn't change regardless of the federal transition. And part of why I want to make that really clear is I know what my mission is. My team knows what my mission is. So we really need to carry out our mission. There are some things in the federal transition that concern me. The narrative that's out there right now, I'm not sure it's constructive from their part, because quite frankly, I don't think anybody feels reassured when they're talking about just blanket cuts to everything, because one of the things it kind of implies is that things weren't thoughtfully constructed. And one of the things I've just noticed is that most health policies, whether you like them or not, are thoughtfully constructed. And one of the things I've learned too is that it's just really hard to deconstruct something without hurting people. We have a really big Medicaid program in New York State, really big. We have a really big Affordable Care Act program in New York State. We call it the Essential Plan. When I say in New York State, I mean $13 billion from our Essential Plan. Our Medicaid program is $83 billion. These are really big programs for us. They just can't be changed quickly without hurting people. And one of the things that concerns me is when you hear this narrative, I understand they're appealing to a certain mindset, but what you say to some people, they might hear save money. What other people are hearing is you don't care about me and you're willing to hurt me. And that concerns me. Now, one of the things I'll throw out there too is when I look at just issues like vaccines, well, states regulate who gets a vaccine. So that's something I still have a great deal of control over with the legislature. When you look at fluoride, that's local municipal governments that regulate who gets fluoride in their water. And those are things I can use my voice and be helpful on. And then for other things, when it comes to, insurance, we do have some protections built in, right? Like Medicaid, for example, just cannot be deconstructed quickly. Same with the Essential Plan. Like, our 1332 waiver, our Affordable Care Act waiver right now goes through most of 2028. So you just can't change these things on a dime. So I don't know how much of this is just people talking, but I worry sometimes people don't understand the measure of their words and how it creates anxiety and stress in real people who are trying to lead real lives in New York State and the country. And a lot of people in New York State and the rest of the country struggling day to day. And these conversations where you hear these words thrown out, they're anxiety provoking and they're not helpful.
What do you recommend for those of us in this room, in person and virtually? We want to make sure that our kids can continue to get help.
Yeah, I think there's a lot to be said for staying informed, but being grounded to reality and looking at what really can change and what is just narrative. And part of why I put it in that context is you just shouldn't expect things to change really quickly. But I think there's a lot to be said for using your voice constructively. And your voice constructively means, of course, you work with your local electeds. Of course, you work with state electeds. But a lot of times just using your influence to just, one, be informed about what is the truth. One of the things I think about is we're here at Columbia, right? Institution of higher education. Critical thought is so important. And I think it's really important that we keep ourselves engaged in critical thought and encourage real critical research and look at this stuff that's published and be careful about what we repost to some degree, but also to the extent that it's possible, contribute to scholarly work. If I'm in Columbia, I'm going to say to folks, you're probably in a position to contribute to scholarly work. You're probably in a position to help construct meaningful health policy, not just New York, but the United States. So use your skills, use your talent, and a little bit of a thank you for entering the higher education world, by the way, because that requires a fair amount of commitment too.
We heard a very substantial report on the investment and the amount of monies to be returned, to this nation if we make the $3,600 investment in our children, in the child tax credit, let's say earned income credit, those things, but we also heard that takes time. I mean, do we have the time for that critical thought to play out?
I hope so. I mean, I think, one of the things that are helpful is when you think about tax credits are different than tax deductions, by the way. And I think tax credits are really important. And just because not everybody understands tax code, not suggesting I do, but a tax deduction that lowers how much money you owe in tax or maybe affects a refund. But a tax credit means you get that amount of money if you qualify. So if we have $1,000 tax credit and you qualify, you get $1,000. By the way, $1,000 for a lot of people, it's real money, it makes a real difference. And people do real things like buy real food and pay real rent. And those are real important things to do, right? And it's really interesting to me, like when you think about one of the things we saw during the pandemic, there was a lot we learned from the pandemic. And I worry sometimes we're too willing to forget some of those lessons. But when you think about the earned income tax credit during the pandemic, we think about some of the direct aid to people during the pandemic, those are real beneficial to real people. And people weren't running off willy-nilly, just gambling at casinos with that money, right? They were paying rent, buying real food, doing real good things for their children. And one of the things you saw during the pandemic, which really was a terrible thing for us, but like a lot of good happened during that time for children. And that's a good thing.
Yeah, well, the poverty rate was cut almost in half,
Because of a lot of things that the government did
right.
that really weren't that complicated. They
Right,
gave people money.
Right. Expanded, and it also came to them in monthly installments too, which was essential. And another two pieces of that have to be considered are our undocumented children that need to be supported, and the babies that are now covered in New York State, at least. A word about our podcast. Jeff Madrick, my partner in this project, wrote the book Invisible Americans, The Tragic Cost of Child Poverty, and supported a lot of the work that was done here to try to get the child tax credit. And Chris, I think you remember Jeff saying, or people telling Jeff, it'll never happen. Of course it happened. Our philosophy at the podcast is give the parents the money, give it in cash. Don't ask them any questions, but we understand name and address may be necessary. But to sort of eliminate, this huge structure that, feeds itself and not our kids.
Well, I think there's a fair amount of wisdom in that. I mean, I think parents generally want to do the best for their kids. I think if you can relieve some of that pressure and stress, it gives them space to do that. And you saw a lot of that during the pandemic, but that's where the earned income tax credit in particular can be really helpful for folks. But I think it really gets this larger issue is like, how much do you need to control parents? And I think to a larger extent, it's better to let parents do the right thing for their kids. They know what they are. I like to reduce barriers. Like when I think about nutrition for kids,
right.
I'd love the WIC program to be as available as possible for everyone who qualifies. But in New York State, for example, only 57% of those eligible for WIC are even signing up for it. Now, we're trying to get more people to know about WIC, but, the federal funding on WIC it's been kind of flat for the last decade or so. And this is one of those things where I think when you look at health equity, one of the things I think about with health equity is, and by the way, when I talk about health equity, just so I know we have a common definition among us here, is I think about health equity work as being intentional work. And one simple way of defining it that we use at the Department of Health is just recognizing not everyone has the same starting point in life. Not everyone has the same advantages, yet everyone deserves a fair and just opportunity for the best health outcomes. Now, when you look at WIC, achieving health equity actually benefits everybody. And here's an example with WIC how, right? When you look at how does achieving health equity benefit everyone, nobody benefits from children being hungry at school. No one benefits from children being hungry, period, right? But what happens when children are well-nourished? Do they do better in school? They do. What happens when children are well-nourished? They're happier. What happens to their parents? They're happier too. When you think about WIC, it helps people who are pregnant too as well. Like there's no advantage to people who are pregnant not being well-nourished. And this is one of the reasons why it's really important for us to help WIC become those who are eligible. We'd like everyone eligible to get WIC. And I think it's just another example of how when you achieve health equity, everyone benefits. And I think we need to move away from health equity being like the haves giving to the have-nots. That's really not what health equity is. Health equity is really about recognizing not everyone has the same starting point in life, not everyone has the same advantages, but everyone deserves a fair and just opportunity for the best health outcomes. Remember one of the advantages I talked about earlier? I grew up in a family business. Most people don't have that advantage. That really helped me.
Right. So almost every single survivor of child poverty that we've interviewed on our podcast has expressed the experience that they still relive of being with their mothers in some government office trying to fill out the paperwork and watching their mothers lose their minds either literally or figuratively because it was just too complicated. What's your view about the paperwork that's required? I know that there are federal requirements to that as well as our state part of it. Have we done everything that we could do in New York State to simplify the process?
So I think, we're trying to simplify the process. I've actually talked to our people about this week too, about what we can do to even simplify it more. But there are federal requirements we have to meet in this regard. And this gets to that, notion about having to verify things, and I think one of the things that I worry about sometimes though is if you create barriers, are the barriers there to verify information or the barriers to exclude people? Carol, I talked about, I have 3 kids, 2 with different forms of autism. My Noah and my Christopher would have an awful hard time navigating any form. Well, what if we weren't there with them? They
Right.
wouldn't be able to navigate that. A lot of why we moved back, by the way, had a lot to do with, when I moved back. I mean, I remember saying to my wife, we're in Rhode Island living a perfectly happy life, but it was March of 22. The pandemic was coming in Rhode Island. I sat around the kitchen table with my wife and said, it's time to go home. And here's the question I posed to my wife. I said, when you and I are dead and gone, where do you see Noah and Christopher spending Christmas? And we had nothing because it's a beautiful state, lovely people, but there's no one around them. The point I'm making is family members are a powerful social determinative of health. So we moved home to be around extended family too, but therein lies, what can we do to make things simpler? Like, for example, we have the New York State of Health where you can sign up for Medicaid or the Essential Plan. My team's done a lot to simplify that, but it's still a process because you got to go verify through all these federal databases. On the other hand, people are figuring it out, but we have over 1.5 million people in our Essential Plan. We have over 6 million in our Medicaid program. People are figuring it out, but it takes 45 minutes, but you're going to answer in real time. It used to take weeks, but we have it now down to 45 minutes. One of the things I've challenged my team to do is like, how much simpler can you make it? Because really one of the things I want to get back to is barriers, right? Are barriers there to verify people or are barriers there to keep people out? Because I think you have to be really careful. What is the barrier doing? Because keep in mind, men, with health equity, when we achieve health equity, we all benefit if everyone has health insurance, right? Just another example, right? If everyone had health insurance, we all benefit, right? Because hospitals get the money they need, healthcare providers get what they need. But more importantly, people have the healthcare they need, right? Not just paid prenatal leave, but they get all the colonoscopies they need. So I get the colon cancer identified early. They get the mammograms they need to find the breast cancer early. They get the cervical cancer screening done to find the cervical cancer early done. But by the way, it's more than just cancer screening, right? Like, in other words, we identify everybody with hypertension, so there are not as many people going on to have strokes. There's a lot of things that happen when everybody has health insurance. And that's another example. When we achieve health equity, everyone benefits.
So let's go through a couple of the things that we always talk about, for instance, homelessness or the unhoused, unsheltered. There's a data that you could check every single day, and I do many days. It's how many children spent the last night in a New York City shelter. I think it's close to 40,000 last night, the night before 40,000 children. We know 135, 150,000 during the course of the year who have been without shelter, without homes. But importantly, the figure of stress because of all of that. It's not just the house itself, it's the stress that's going up, and the suicide rates for our kids is astronomical.
Yeah, anyway, so this is one of the biggest stressors for people, right? Is if you think about housing, if you don't have a place to put your head at night, if you don't have an address, those are really disadvantageous social determinants of health, probably the worst, right? Because when you really think about one of the things that you really need to maintain optimal health and well-being, you need one, security, knowing where can you put your head at night. This is probably one of the governor's top priorities is housing in New York State. Housing, there's a lot of things that did get worse during the pandemic. Housing was one of them, not just in New York, but across the country. But housing prices, although it may be good for people who own a home, create real barriers to people trying to acquire a home. Rent prices have been right up with it here. Housing's a real barrier. And it's one of those things where it's sort of hard as a civilized culture that this is something we're still struggling with. Because obviously the technology exists for everyone to have a home. Obviously the space exists for everyone to have a home. And really housing is such a critical social determinative of health.
Any solutions to that from
Well,
your
the governor
approach?
did quite a bit with the legislature last year to require more housing to be built. That's part of it. It's funny, probably one of the little known things people maybe don't know that we do in Medicaid is we actually help people get housing. We have a supportive housing program. Like, I don't know why anybody would know this, but there's about 7,500 people in New York who have their housing paid for by our Medicaid program. You have to qualify for that, but it's just one of many programs in New York that helps people find housing. And when we look at the supportive housing work that we've done, and you have to qualify for that with certain chronic conditions, we know that there's lower total cost of care, so there's a return on investment if we help with that. One of the things I want to bring into the conversation, though, is there's something we did in New York State called the 1115 waiver.
Precisely.
Yeah, and there's really, by the way, there's no reason why anyone should know what the 1115 waiver is, but if I could just negotiate this briefly with you, it's an agreement the Department of Health made with the Office of Health Insurance Programs, part of the Department of Health, made an agreement with Center for Medicare Services. It's a $7.5 billion agreement. It goes until March 31st of 2027. When I say in this agreement, by the way, when anything's got a waiver attached to it, the question you should ask is, well, if you're a waiver, what are you being waived from, right? So when we did the 1115 waiver, it's demonstration projects. What we negotiated for over a year with CMS was, we'll do these demonstration projects. And if we do these demonstration projects, we think they'll lower the total cost of care for Medicaid. And so we'll do these projects, but we want you to give us money to do it, and a lot of it. So they did, right? So that's a cool thing. But one of the things in the 1115 waiver is something called social care networks, $3.4 billion to create 9 social care networks across New York State. Now, what are the social care networks? What social care networks do is create these networks, these 9 different entities that will work on optimizing individuals' social determinants of health, helping people have advantages. If your problem is housing, helping you secure housing. If your problem is transportation, helping you accomplish transportation. If you're going to the emergency room all the time because you have a primary care provider, help with that too. And part of what I'm saying is what you see where CMS went, where the New York State Department of Health is going, is recognizing if we're just going to focus on paying for care that goes on in an exam room, emergency room, operating room, delivery room, or any one of those other rooms, we're spending a fortune on healthcare. But am I really keeping you healthy? Well, the answer is no. Because when you think about really what keeps us healthy, it's our social determinants of health, right? Like what's going to improve the length and quality of your life? You need adequate housing, reliable transportation, a good social network, you need decent education. You need to make sure that your abilities are allowed and you're allowed to understand things in the language. These are just a few examples of social determinants of health. I call those advantages because if you have positive social determinants of health, you have advantages. If you have negative social determinants of health, those are disadvantages, right?
Are you sure that that is secure until, when does that
So
expire?
this waiver, the 1115 waiver, expires March 31st of 2027. And, the language of the future might be return on investment. So we're gathering a lot of data as we're doing this, and I'm confident we'll show a positive return on investment. So we'll see where things go. New York's a big state, though. I think one of the things we have to kind of accept is New York's a big state. When I talk to the governor, she's never shy about telling me what her top priority is. It's the health and safety of New Yorkers. She's never ambiguous about that with me. So, she's very committed to New York becoming a healthy and safe state and also making it a very affordable state.
One of the things I noticed is that you have a program. We were talking about the Black maternal health rate, which is astronomical. And as we know, we can probably guess that you probably, as you go through, you see very few Black doctors, medical staff, and you have a program that I think, though, is listed under DEI, where you're training Black doctors and health workers. I mean, and this is something that seems to be on the cutting board of a future administration. Anything that, would help. I think the rate of Black doctors is, what is it, under 5%, 7% in this
It's
state?
disproportionately small. And so one of the programs we have that you're referring to is something called diversity in medicine, where it's an agreement the legislature and the governor have, where each year we put a certain quantity of money aside. I think last year was $2.7 million. Then there's some matching funds from Mother Cabrini. But one of the things we do is, and I'll just give you an example of how the diversity in medicine program works. Just say, for example, you're someone who went to college and you applied to medical school and you didn't get in. That's sad. And, the medical school said, well, I think you're someone who really would have been a good physician, but your grades just didn't really meet the standard. So what they'll do for that individual is help them what's called a post-baccalaureate program. So you then go to the medical school and do a 5th year of college, if you will, and you learn some of the basic sciences so that when you do enter medical school the next year, because you're conditionally accepted at medical school, that you then enter that medical school. And so in the diversity of medicine program, There are literally hundreds of physicians in New York State right now who've gone through the diversity in medicine program. That's one example. Other things they do in the diversity in medicine program, though, is help actually people pay for medical school at the SUNY rate. So they will pay tuition for that. And there's 17 medical schools in New York, all of them who participate with this program. But it's an example of a really good program because really one of the things we have to acknowledge is when you go to see a healthcare provider, if the person doesn't understand your culture, your healthcare experience is different and not as good. You know, there's data that supports that. So really important in healthcare for us to have what's called cultural competence. It's something that I've tried to do. I mean, and you know, obviously when I went to work on the Navajo reservation, I'm not Native American. However, I was extremely intentional about learning the Native American culture. Like one of the things I learned when I was working on the Navajo reservation is you don't shake someone's hand with a firm handshake. It's considered rude. So you don't do that. The other thing I learned was, and this is important as a pediatrician, is in the Navajo culture, there's something called a first laugh. And when the first laugh occurs, it's your responsibility to throw a party for the child or buy him a goat. And it's a beautiful tradition, right? And it happens around 10 weeks of life, very close to the 2-month well checkup, right? So one has to know if you cause the first laugh, if you're the reason for that, then it's your chance to throw a party. And I saw colleagues of mine do that, right? But it's part of cultural competence. But could you imagine if you're a rich white doctor working on the Navajo reservation and you weren't willing to honor that part of the culture? The message you sent is memorable and it's not a good one.
Yeah, so how much do you think racism plays a part in the situation that we have today? Is that a determinant that you factor into the work that you're doing? Just pure racism having nothing to do with where you were born or how much you were born with. There's just flat out racism.
I think we, you know, so let's talk about implicit bias first. I have implicit bias, just so you know. I'm going to own that for a little bit with you, right? I have what's called implicit bias. Before you judge me, you do too. That's why it's called implicit bias, right? So we all have implicit bias, right? I own that because I'm still a learning individual. And one of the things I recognize on my journey throughout life is that, wow, how do I act and how does that approach and how do I think about things, right? And then there's something called systemic racism. There's also systemic sexism. I don't think we talk about systemic sexism in the United States nearly enough. But I think
Even so, after
no, I really don't. And I think it's really important to own there's a lot of isms that are baked into our culture.
right.
And if we're not willing to understand that we're baked into our culture and therefore contributes to our own implicit bias, we come across a certain way. And obviously systemic racism is a big issue, but you talked about pure racism. So I got to get back to what you talked about.
Okay.
And of course, pure racism is a problem. And I think, you know, one of the things I saw in the most recent election cycle, which was a little bit memorable for a lot of reasons, was just how overt racism was not just allowed, but by some celebrated, which disturbed me deeply. And we still see this in healthcare, and we still see this in our culture. Now, you referenced earlier Black women having a 4 to 5 times higher mortality rate than white women. You know, that concerns me deeply. But that's not just because of racism in healthcare. Oh, yes, that's a problem. But that's racism outside of healthcare too. Because one of the things I think we have to own is that if we're ever going to get ahead of maternal mortality, that's intentional work we need to do in healthcare. But it's also intentional work we need to do outside of healthcare. We need to own that overt racism and recognize it's wrong, call it out when we see it, and move beyond it, but also remedy that has real adverse health consequences to individuals. And it's one of those things where if we aren't willing to embrace it as a culture, we're not going to see the success we have. You know, and it's interesting. Sometimes we say we've come a long way with racism, but it is exhausting when you're a victim of racism to constantly be fighting these battles that should never have existed in the first place. And right now, you referenced earlier, like to not be able to talk about diversity, equity, and inclusion. There are a lot of people when they see what the future could be, they're exhausted by that, saying, "Are you kidding me? You don't see the value in diversity, equity, and inclusion. You don't see the value, and you actually want to take it away." And you see large companies moving away from this when it's like, of course, this is critical. In the New York State Department of Health, not only do I think diversity, equity, and inclusion is important, I have someone who is in charge of that. And I have a group of people who work with them to make it more widespread throughout the entire Department of Health. Because even though we're the Department of Health, of course, I have a problem with racism in my organization. Every organization does. And if you're not willing to embrace it, you're not willing to solve it.
Do you think that your state policies will survive a federal demand to dismantle any of those kinds of things?
I think so. I really don't. I mean, New York's a big state with a strong governor. And, I really don't think we'll be bowing down to anybody who's going to make us compromise our values. And a lot of it we control. But, one of the things I think that we have to own is like when I see what the future of who's leading the health world might be, be careful what you ask for, my friends. I don't know if you know what you're getting into. It's one thing to have ideas, but when you look at someone who might lead the largest enterprise of government who has no real leadership experience, that might come down crashing down really quickly here. And, the other thing I'll just say is like, DC is not the easiest city in the world to work in. I've lived there twice in my career. And there's an old expression in DC, if you want a friend, you get a dog. And I'll just say is like, let's see how the confirmation process unfolds with all of this here, because it's just getting started here. But, people who lead, for example, the CDC have an amazing responsibility. And if you, I'll just throw this out to you, like, it's hard to lead large organizations. Like if you're wondering if my job is hard, oh my gosh, it is, right? But if you want to lead the CDC, that's a really hard job to do. But for example, let me give you an illustration of what you're not talking about today. By the way, no one in this room woke up this morning and say, I wonder how we're doing with Marburg virus in the United States. I wonder how we're worried about, nobody cares about Marburg virus in New York right now, right? Why aren't you worried about that? Because it was in Rwanda, but why don't you care about it right now? You don't care about it right now because months ago, the CDC deployed people to Rwanda, brought with them over 1,000 doses of vaccine, albeit in a clinical trial, administered to people, brought with them expertise in personal protective equipment, brought with them experimental treatments, helped mitigate the problem in Rwanda. So less people were dying from Marburg. But wait, there's more. Helped put in the safety guards so that when people are leaving Rwanda, that people were screened. Had people come into 3 airports in the United States, so if they came, they were screened and we knew where they were, interacted with state and local health departments. That type of purposeful infrastructure, that's what a functional CDC does. There's a lot of examples for how we benefit, by the way, all of us do, from a very functional CDC. So if you want to lead the CDC, buckle up. It's a hard job. I hope you can do it.
And you're giving props to RFK Jr. I take it you
think they were props. I mean, was I misunderstood? What I'm saying is be careful what you ask for. By the way, I love a healthy diet.
Okay, let's talk.
I love the idea. By the way, New York State Department of Health has never told you to eat processed food or drink sugary beverages. We've never told you to do that. We're not now either, right? And one of the things I'll acknowledge, though, is why is food processed? It's processed to make it more palatable, affordable, and transportable, right? And you know what? We have food deserts, not just in New York, but across the United States. We have food deserts. I would love to see fruits and vegetables and real foods in every neighborhood in New York State and in every part of the United States, right? So if the federal government wants to help every state find a way to take this beautiful breadbasket of a country we have and transport the fruits and vegetables close to real time everywhere we need them in the United States, I would love to see that. I would love to see kids not eating Pop-Tarts for breakfast. I would love to see kids eating real food for breakfast. I really would. I would love to see kids eating not Twinkies ever. I mean, I'm just going to tell you that. I'm just not a Twinkie guy. But I'd love them fruiting, enjoying apples and other fruits and vegetables and enjoying the power of nuts. And part of what I'm just saying that is like, there's certain things that if the future happens, we'll find places to work with people. But I do think nutrition is really important to people. Any help I can get in that space, I'll take it.
Okay, great. Now, are you begging people to take COVID shots or not? Where are you in that regard? There has our system in vaccines already been corrupted in some way?
Yeah, I'm not begging anyone to do anything anymore. And I want to bring it back to the pandemic, my friends, right? But
you're not going to do those television, commercials saying, please, no?
No. Let's talk a little bit about what we did to each other during the pandemic, right? And I think part of why you don't like public health anymore, my friends, is when you think about the pandemic, the position public health professional could put in is we told adults to do better. You weren't wearing your mask right. You're too close to other people. You went to a bar when you weren't supposed to. You had a party in your house and weren't supposed to. We kept telling people to do better, and part of why I wanted to say that is that adults don't like being told to do better. By the way, kids don't like that message either, right? So let me just bring you back to what my communication strategy is. I explain the why and help you decide what to do, right? So Carol.
Yes.
If you don't get a COVID vaccine, your risk of ending up in the hospital is higher. And I like you. I'd rather you not be in the hospital. By the way, if you don't get a COVID vaccine, your risk of passing away from COVID is higher. And I really like you. I'd prefer you not to pass away. Carol, it's up to you what you want to do. I think it's in your best interest to get a COVID vaccine. Are you interested?
Yes.
Well, thank you. So that's how I beg people, if that's what begging looks like.
Right, right. So let's, in a closing note, although you're wonderful, Kate, we have to have him back again. It was just wonderful. To our children, what's your advice to this room, the virtual room, the outside world, in terms of how we actually put a stop to the hunger and the unhoused situation and unhealthy to the point of this situation?
So let me give you a framing thought first as a parent. And I figured this out as a pediatrician a while ago. And I don't know if you guys are parents too, but I had this epiphany once as a dad. And what I'm about to tell you may disturb you, and it's going to put an enormous amount of pressure on you if you don't hear it correctly. So please, you were warned, right? I realized I give my kids their childhood. Let me give you that again. I gave my kid every Christmas. I give my kids every meal. I give my kids every night to sleep in. I give my kids every moment of their childhood. As a parent, I give my kids their childhood. Guess what? Others do too. Their teachers give them their childhood. Their doctor gives them their childhood. The community around them. We all do that, right? Part of why I want to give it to you in that perspective is you are all part of giving other children their childhood. Like it or not, if you interact with a child, you might become part of their childhood memory. Now, kids aren't to blame for anything in this world. They're just not, right? You might say, have I ever seen a bad kid? I'm an old pediatrician. No, I actually haven't. I haven't seen bad kids, right? So here's what I've noticed about children is they do respond and they do react and they do reflect. When I see kids who are acting inappropriately, sometimes it's disease. They don't feel good, and I can make that better. Sometimes they reflect. They're learning things that are helping them reflect in a way that isn't healthy. And then that usually has a different solution. But one of the things I think it's incumbent upon us to say is, as policymakers in particular, is how do I help give kids a healthy childhood, right? So obviously, when the governor is looking to make sure we have stable housing for everyone in New York, I'm a real big fan of that, right? So I work with every state agency possible to help with housing. You'd be surprised how much the health department helps everybody else do that, right? When I think about how we can make sure nutrition's optimized in kids, that's really important to me as well. Not just for our state agency, but OTDA, and there's other state agencies that help people have nutrition as well, ag and markets. There's things we do, right? But there's how we help. But this gets to other things too when I look at the healthcare marketplace. And you'll notice I use the word healthcare marketplace, not healthcare system. It's one of the little myths out there, right? No state has a healthcare system. Every state has a healthcare marketplace. And if you have a card, and just importantly, you know how to navigate with the card, you get varying quality levels of healthcare. But I'm trying to improve healthcare so that when you go access healthcare in New York State, one, you can afford it, two, you can access it, and three, you can count on the quality being consistent. Those are some of the things that I share with you. I gave you enough to reflect on. Some of you absorbed some of that. I hope that was helpful to you.
Thank you. Thank you so much, Commissioner McDonald. We appreciate it so much. Kate, did you?
Thank you. Thank you, Commissioner. And we had promised that we'd let the commissioner go at 1:45, but I'm hopeful maybe one or two questions.
I can stay till 2.
Okay.
So here, just so you know, my afternoon looks like I have to get in the car and drive to Albany.
I'll be
But I have meetings in the car, but nothing starts till 2:30. So,
great.
but I want to get home eventually so I can spend time with my wife and my kids.
All right. So really, I'm going to say 2 questions or comments. If folks want to ask them. Brian, I see your hand sort of raised. Can you turn on your mic? We have people listening virtually too.
Can you hear me? Oh, good. Love technology. Thank you, Commissioner McDonald, for your presentation. I work for the State Assembly. Expanding health equity is incredibly important to me as well. I come from the HIV/AIDS policy space. The governor's office, and by extension, the Department of Health, has had an opportunity to expand health access to very vulnerable populations, including the undocumented population, through the 1332 waiver, which would allow us to use pass-through surplus funds in the 1332 trust fund in a pass-through account to provide healthcare to undocumented New Yorkers. CMS has said we could do it, right? The state legislature has supported it in their one house resolutions. Why has the governor's office, and by extension then, the Department of Health, not recommended that the governor's office submit a waiver application to provide these communities with healthcare? Obviously, with the Trump administration coming in, this is not going to happen for a couple of years, but because the values of DOH and by extension, the second floor are to expand access, I'm curious, what is the delay?
So we did what we could because here's what we could do. We could get children covered who weren't documented, and we've done that. We could get 65 and older covered, and we did that. We could do the deferred action for child arrival program, so we got that done. We could do people who were pregnant, so we did that too. We got done what we could get done. When you ask the honest question about why we didn't do more, a lot of it has to do with just the national politic about this issue and how it influences New York. And so that's not maybe the answer you want to hear, but it's the honest answer.
That is the answer.
About what this is all about right now, right? And I think one of the things we have to own as a country is we have this welcome sign out front. I don't know if you guys have noticed it at Ellis Island, but she's standing up there holding a torch and everything. Everybody sees it, and there's even words inscribed on it, right? So, and you know, one of the things I want to own with you a little bit too is I told you before, I'm not a Native American. So my ancestors immigrated here from Ireland and from Italy. But what was different about that was when my ancestors immigrated here, they were allowed to literally get off a boat because that's how it occurred. And they were allowed to go to work. So that was a powerful advantage, right? And I want to just bring that back a little bit. That's why it's such a powerful advantage is because my ancestors were allowed to do that. Oh, they struggled, you know, and their struggles documented, but they struggled. But they actually were able to succeed. And then they built generational wealth. And then it helped my great-grandfather, then it helped my grandfather, helped my father, helped me. Do you see how the generational wealth was really a good thing, right? But do you see where one of the big changes was they were allowed to work right away? Even an asylum seeker now who's documented is unlikely to be able to work for 8 to 12 months. So now they'll be eligible for the essential plan though, so I can get them covered, right? But I think one of the things we have to own is who of us would be able to move to any other country on the planet and be able to survive for a year on what we brought. I would say that would be very few of us. So I'm concerned about the conversation that we're hearing. And, you know, when you think about why are people coming to the United States who are undocumented, my experience is they're just trying to flee an awful situation. It's the narrative out there I thought wasn't helpful. But my experience is the people who weren't documented were really trying to just flee a terrible situation and trying to find a safe place. And, you know, I learned this a long time ago when I was in the Navy is the very worst day in America is still better than the best day a lot of other places. And it always will be. And there's always going to be people who will do whatever is possible to get here. It's a great place to live.
Thank you.
Thank you.